Norepinephrine is exciting, no pun intended, and I am looking forward to offering you considerably greater information on norepinephrine, really help make norepinephrine the very important neurotransmitter it is. But before we go any further, we do have to establish the fact, is norepinephrine important in psychiatry? So look at this illustration. Yes, it's important in mood regulation. You and I have known that for about 70 some years. But on top of that, it's incredibly important in cognition in both directions. Wait till I show you what it does. Inflammation. In fact, with long COVID, the number one neurotransmitter we think that's implicated in long COVID is actually norepinephrine. Wait till I show you the evidence. It's also involved with metabolic control. It's involved with sleep-wake regulation. It's involved with aggression, irritability, as well as excess withdrawal from social life. As Pratap was saying, disconnection is at the heart of depression, and norepinephrine is incredibly connected to connectivity, not just in the human brain, but also with society. This illustration I'm about to show you is perhaps at the heart of understanding norepinephrine, and it's this. Neither low nor high are any good with norepinephrine. That's certainly true for nature, but I really want to emphasize with the norepinephrine, as a psychiatrist, my goal cannot be to increase or decrease norepinephrine. It really has to be to do what is necessary for that patient. So low norepinephrine, we do know, is quite involved with fatigue, cognitive inflexibility. People get ruminative in those states. But I also want to talk about what happens when norepinephrine is too elevated. And I got to see it this weekend. I was at a CME meeting and I watched a presenter on stage talk about burnout. She had gone through it herself and she was doing an eloquent talk. But then she started talking about how burnout had affected her personally during COVID. And I saw something fascinating and painful, actually. What happened is she started freezing. As she got more anxious, instead of becoming jittery or sweating, she did the complete opposite. Her words slowed down, they became monotonous, and she actually briefly from stage dissociated. To the point, her fellow presenter actually stepped in, put her arms around her because she was physically, cognitively, and verbally frozen. I saw what norepinephrine can do when it is in excess amounts with my own eyes only yesterday. And this happens in our patients all day long. So norepinephrine is a challenge when it is abnormal at both ends of the spectrum. And therefore, our goal in many ways is not to be an increaser, decreaser. It's not. In this particular colleague of ours, she's a fellow healthcare professional, she certainly was overactivated yesterday during the lecture. But my fear is there are other times that she's way underactivated. That dial for her and for our patients may be going in every which direction. So Pratap was very eloquent. He was gentle about it, but it was devastating what he showed us in terms of how limited DSM is in our ability to understand psychiatric disorders. So NIMH, National Institute of Mental Health, almost 15 years ago proposed the following, and I know you're aware of this. This is called the RDoC criteria. They no longer talk about just symptoms. They talk about these valences. And well, why don't I show it to you? It'll make a whole lot more sense after I show this to you. So there are 5 valences that we human beings live on. 5, if you will, spectrums. And when all 5 of them are in balance, we are in a state of good mental health. But what's very interesting is if any of them, negative valence, like excess fear, depression, positive valence, not enjoying anything, cognitive, underfocused or overfocused, social, excessively engaged or pulled back, and arousal and regulation of the mind and the body. These are the valences involved in human psychiatric pathology. And these are so much more appropriate in terms of understanding the brain networks that Pratap was showing us earlier as to what goes wrong with them, to better understand the role of norepinephrine. And if you're interested in norepinephrine, the best thing to remember is norepinephrine is involved in all 5 of these valences: negative, positive, cognitive, social, and arousal and regulation. Norepinephrine is very important. And the fact that in psychiatry, over the last few decades, we have underplayed its importance is much to our and our patients' loss. So the important key message I would love to share with you is this: norepinephrine is transdiagnostic, meaning it doesn't belong to depression or anxiety or Alzheimer's or panic or PTSD, or I could go on. It's transdiagnostic. The moment you pull the thread of norepinephrine, it becomes clear. It's involved with a huge number of disorders that could be all the way from anxiety, which is internalized, to aggression and irritability, which is externalized. So please do reflect on this. It's worth doing it. It's worth doing it. Transdiagnostic, how does it apply to norepinephrine? It tells us the following: there are no sharp edges to norepinephrine in terms of only this disorder or that disorder. It does also mean norepinephrine can and does pop its head into multitudes of conditions and human disorder presentations. And it can, depending on where it lives on the spectrum, too much, too little, can produce what may seem like paradoxical responses, but they're actually connected. Take-home message is simple, very simple. To understand norepinephrine is to understand psychiatry. To understand norepinephrine is to better serve the diverse needs of our patients. Time to transition, folks. It's time to talk about actual role of norepinephrine in disease states. And I think my screen just froze. Let's get it back. It's back. So norepinephrine, as you well know, is distributed in the human brain, true, but its origins are not all over the brain. And this is the trouble with norepinephrine, is its origins are below the thinking part of the brain. They're in the locus ceruleus. So the locus ceruleus is certainly under control of cognition and emotion, but it's also an independent entity. It doesn't always take orders from your brain. So that's why norepinephrine dysregulation often feels so automatic. So when you see patients with PTSD, for example, they're well aware the threat is gone. They know the perpetrator of their abuse is no longer even in this world, yet their body and their brain acts like the threat is imminent. So please remember, norepinephrine, in terms of its origins, is not in the cortex. It's much more in the brain stem, in the locus ceruleus. And certainly from there, it projects to all kinds of places. And this point is so important. I hope you'll allow me to re-emphasize this issue, which is low norepinephrine is indeed a challenge, truly a genuine challenge, and so is high norepinephrine. As a clinician, we should never ever be interested, as I've said before, in decreasing or increasing. It is really bringing it back to the state of normal homeostasis. And by the way, norepinephrine is just a neurotransmitter. Neurotransmitters don't work unless there's a receptor. And norepinephrine, being the clever, hardworking neurotransmitter that it is, actually has an army of receptors. In fact, it has 9 receptors. Psychiatry really needs to get to know those receptors, because once we get to know those receptors, you and I can do so much to help our patients. So allow me to very quickly give you a classification of that. Okay, here we go. So they're broken into 2 families, the alpha family, the beta family. Let's talk about the beta family. We'll start from the bottom up. Beta 1, beta 2, beta 3, and they're quite different. They have quite diverse roles. They not only are anatomically located in different regions, but they have different roles. Perhaps some other time we'll have an in-depth conversation about beta receptors. Today, let's focus on the alpha receptors, the alpha family. So the alpha family actually has two daughters. Let's use the family analogy, alpha 1 and alpha 2. Circuitry is deeply engaged in both alpha 1 and alpha 2 family. The reason why we're so deeply engaged, our patients' brains are deeply engaged with alpha 1 and alpha 2. So alpha 1 has further three daughters, so you might want to think of them as granddaughters: alpha 1A, alpha 1B, alpha 1D. Why are we doing all this classification business? Because they have such diversely different roles. Anatomically, the alpha 1 family lives post-synaptic. Alpha 2 family members, we have alpha 2A, 2B, and 2C, live both pre- and post-synaptic. And when they live presynaptic, they act as autoreceptors. That's a lot of words. What does this mean? This is what it means. That the family members in the alpha do not increase or decrease norepinephrine. What they do when they work in conjunction and together, they actually bring the highs to the middle, they bring the lows to the middle. It's an inbuilt mechanism of straightening out the norepinephrine tone. It's very important we appreciate that. And it is the receptors that create that benefit. Let's, for a moment, transition a bit to talking about anhedonia and to what Pratap was talking about, to altered reward circuitry. The state of I'm spinning so fast that I'm emotionally locked in. They are circuit disorders. They really are. And we should perhaps dive into it. So there's, of course, a circuit called the default mode network. You can see that in the green. This is overactive in people who have depression and anxiety disorders. Where they're underactive is the CEN, the cognitive executive network. So then the question is norepinephrine too much or too little? And the answer is yes. It is way too little in the cognitive executive network, way too much in the default mode network. End result? We have two sets of pathologies in the same person. The person is so deeply anxious, so deeply ruminative, that the body and the mind acts like and phenotypically looks like it's shut down, emotionally locked in. So now I am happy to illustrate for you that norepinephrine in the same human brain can actually be too much, too little, and actually create human pathology. And in sleep, it's a bidirectional relationship. How have you slept, folks? Right before a big event in your life. You're not depressed. You just worked up in a happy way. Maybe you have a flight to catch at 4 o'clock to go off to some wonderful destination. Isn't the sleep repeatedly interrupted? Norepinephrine's too high. It's sadly making sure you don't sleep too deeply. But the reverse is true. If you have a sleep disorder from whatever etiology, norepinephrine is high, and we know that because heart rate and blood pressure in people who have insomnia tends to be high. So norepinephrine is deeply involved, not just during wakefulness, that 16 hours where we are thinking, interacting, connecting, but it's also involved when we're sleeping. In other words, norepinephrine is a 24/7 neurotransmitter. It's been with us since the moment we were born, and it'll be with us throughout our natural life course. So there we are. Norepinephrine projections are profoundly important in every aspect of why we sleep, and the primary role of sleep obviously is to keep the homeostasis, in particular with our microglia, under check, and norepinephrine excess will not allow that to happen. And another disorder we have that challenge is post-traumatic stress disorder. Norepinephrine has its fingerprints all over that disorder, not just in activating symptoms, not just in flashbacks and anger episodes and rage episodes, but also in the complete opposite, the under-arousal, the withdrawal, the shutdown, the locked-in phenomena. All of that, they seem to be paradoxical, But they're not so once you and I dive into norepinephrine and recognize when norepinephrine and its army of receptors have betrayed the patient. Of course, the end result is going to be the symptoms of post-traumatic stress disorder. And then, I know this is probably going to seem puzzling, but it should not. Norepinephrine pathology is deeply implicated not just in Alzheimer's disorder, but in the arrival of Alzheimer's disorder. This may be the reason why one of the prognostic bad features for developing Alzheimer's, in fact, actually is depression, anxiety, insomnia. And the thread that binds all this appears to be, you got it, it appears to be norepinephrine. So we have been trained, haven't we, in medical school over decades to think of Alzheimer's as a cortical problem. We talk about tangles and plaques. Where? In the human cortex. Well, little did we know. The first place Alzheimer's dementing illnesses present themselves is actually the hippocampus. That arrives before almost anything else. And the hippocampus is deeply innervated by norepinephrine through its army of receptors. So the emerging evidence actually is, I just circled it for you, both in health and in illness, like Alzheimer's illness, norepinephrine chronic pathologies may actually play a large role, which probably explains why so many of our patients who have Alzheimer's also are agitated, angry, irritable, all of those features that we've talked about. So if you wanted further evidence on it, and during Q&A we can cover it as well, norepinephrine and locus ceruleus, not surprisingly, are deeply involved in the pathogenesis, not just of Alzheimer's disease, but on the manifestations of Alzheimer's disease, such as deep sleep disruption. I have sadly, 2 family members of ours sadly died as a direct result of Alzheimer's disease. And it was really amazing. Memory was one of their lesser problems. It was confusion for the patient, irritability, and all of that, sleep disruption. And real dramatic change in their ability to modulate their arousal and their calmness. That was very impaired in both of my family members. Yeah, norepinephrine does have to be respected. In the last 10 minutes that I have with you, I would like to talk to you in further detail about the locus ceruleus's firing abilities, because if we understand this well, we could really help our patients with both tonic and phasic abnormalities they face. So what is tonic? Tonic is steady state background firing that neurons do. This probably is the reason why when norepinephrine is disrupted, patients report fatigue and cognitive dullness. But then there is such a thing called phasic firing. Phase, not tone, zzz, but phase. Beep, 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 beep. That phasic firing is actually quite abnormal in people who have norepinephrine pathology, which leads to them being jumpy, vigilant, irritable, almost always locked into the fight or flight response, and often get there at a moment's notice, often associated with panic, PTSD, etc. And I want to tell you, these are not hypothetical concepts. These actually show up in clinical practice. Let's focus on hyperarousal for a second, and please look at the title. Hyperarousal symptoms in psychiatry with the norepinephrine neurotransmitter are very common. And to prove my point, I'm going to show you 6 cardinal symptoms that will clearly demonstrate that. So check it out. These are the 6 cardinal clinical symptoms: dyscognition, social avoidance, fatigue, sleep disruption, anxiety symptoms of multiple kinds, and irritability and agitation. Now, you just have to reflect on this. How many such patients in the last week where they had 1, 2, 3, or more of these manifestations that presented in clinical practices with us? And the answer probably is at least 30 to 50%, if not more, of patients have some kind of such disruption. And you might say, oh, it's hyperarousal, it'll come on down by itself. Well, here's the problem. Remember, the locus ceruleus is not entirely under the control of the cognitive and emotional centers of the brain. They have their own independent charter as well. And here I'm clearly showing you hyperarousal symptoms in major depression are in fact directly correlated with fatigue and difficulty concentration. And you might say that's paradoxical. More norepinephrine must mean good things. Well, up to a point. Up to a point. And after that point, when you go over that rainbow, over that top of the rainbow, sadly on the downside, there is nothing positive. Fatigue and difficulty concentrating lives there. So perhaps we should all challenge ourselves into asking this important question. What is our comfort with identifying and addressing hyperarousal symptoms in our clinical practices? And if we are not at the comfortable or very comfortable range, let's work on it together. These hyperarousal symptoms are at the heart of not just a lot of human suffering, but they're also at the heart of family suffering. We often think about depression as a person's illness, right? Mr. Smith is depressed. Well, we should not forget Mr. Smith also has a family. And that family is as much victimized by the person's depression as Mr. Smith is. So hyperarousal symptoms really affect the family a great deal. And those are my key take-home points for us to remember. They are common, these hyperarousal and hypoarousal symptoms. We really do need to develop skills at better identification. Then, of course, when we need to, we will identify them, treat them. We indeed do have SNRIs, SSRIs and SNRIs, and they, in fact, reduce norepinephrine functioning. But the problem is they can often reduce it to a level that patients often develop what is now called an over-regulation disorder. Remember I told you I was at the CME meeting this weekend? One of the presenters asked a question of the audience. How many of your patients, this was amazing, how many of your patients, when they're on SSRIs, SNRIs, after about 6 months or so, now start reporting a flatness of mood, lack of spontaneity? And I think we all expected the numbers to be 10 to 20%. The consensus was about 50%. The problem is they were right. They were right. In a minute, I'm going to show you scientific data that backs up the fact that this over-regulation of the norepinephrine system, not for the patient's betterment, happens in a lot of patients. And these are the classic symptoms. It's not depression. It's actually the absence of emotion, loss of energy. It's the presence of flatness. It's not depression, though. So they don't actively feel depressed as much as they don't feel anything or reduced ability to actually feel anything. Please watch out. This happens commonly, and this happens for a reason. Serotonergic interventions, in fact, dampen the tone of the locus ceruleus, which is great if you have a patient with panic disorder. It's amazing. Problem is, if you're not looking for that, that dampening further adds to the burden of the patient. So be watchful, even with SNRIs. They might be a bit better than SSRIs. The problem is, if you're not being mindful, then we could really run into trouble. And as a result, we are trying to move away from reuptake inhibitors to direct receptor modulators. And this is the illustration I wanted to really look at. There's the presynaptic neuron, there's the postsynaptic neuron. If you recall, I had made a big deal about the alpha family. The alpha family, between them, have 6 members. Remember that? Of course you do. On top, which that would be presynaptic neuron, is the alpha 2A, alpha 2B, alpha 2C. Remember, they're presynaptic neurons. What are they doing there? What they're doing there is they are acting as braking mechanism. So the reason we have autoreceptors in the presynaptic neuron is primarily not to increase norepinephrine, but to actually decrease norepinephrine. Isn't that clever? But interestingly, the same receptor family, along with the alpha family and the beta family, live postsynaptically, where it's a completely different task. Now the main task is to make the neuron fire. So you can have inhibitory control, you have excitatory control. Now you see why norepinephrine is just trying to work really hard, if it's allowed to, if a major pathology isn't present, to modulate, not to increase or decrease, but to actually regulate, sometimes in the same brain at the same time. So another approach to going after norepinephrine is non-pharmacologic. I will be talking about that, and I know Pratap well enough to know in his DNA, Pratap is a true psychiatrist, and a true psychiatrist is not a psychopharmacologist. A true psychiatrist is an outstanding psychopharmacologist, but is also an outstanding therapist, an outstanding educator. But before we go any further, let's make sure we fully appreciate where psychopharmacology is moving in helping us with norepinephrine disruptions. And that is the advent of, in the last few years, a class of atypicals that do not increase or decrease norepinephrine, but actually modulate the actual receptors. So here I've just brought for you two examples. Aripiprazole is on top. Beautiful molecule. What, however, it does not do very well, certainly not at high enough potencies, is norepinephrine modulation. Then we have a molecule called brexpiprazole. Both these molecules are widely available in North America and actually in many parts of the world. Well, brexpiprazole is very interesting. It's one of those molecules that, in fact, make sure norepinephrine is never ignored. So remember, alpha-1 family was postsynaptic increase. Yeah, you remember all that. What it does, it has this effect on these receptors that is highly potent, comes very quickly, and it's more diverse. The assets are distributed widely. So this is just to kind of alert you that atypicals have not walked away from their charge in helping us go after serotonin and dopamine. But it's time to make sure norepinephrine isn't ignored. So let's start wrapping up our conversation, because no conversation about norepinephrine can be complete without talking about non-pharmacological interventions. And this is just a quick, perhaps self-test. How often are we discussing these non-pharmacological interventions with our MDD patients? My guess is all the time, or nearly all the time. But if we aren't there, let's do that. And here's why. Norepinephrine is, in fact, highly responsive to exercise. And exercise is a very good modulator of norepinephrine tone. So certainly when we exercise, norepinephrine goes way up. But the beautiful thing about going way up in these episodic fashion is the underlying tone of the locus ceruleus is improved. Some other time we should talk about the profound neurobiology of norepinephrine in terms of how well it and exercise get along. There we go. The relationship is bi-directional and it's beautiful. I think exercise should be recommended in such a manner that even our patients who are reluctant to consider it will accept even a few minutes of it per day. The other thing is, of course, meditation and yoga. Both of these, for biological reasons, are actually very strong noradrenergic modulators. An error that's often made is people thinking that meditation and yoga dampen norepinephrine. If you've ever done meditation, some things about you calm down. That is true. But other things are very activated in a good way. For example, during meditation practice, what I tend to find in my own personal life is I get very activated in my cognitive network. How do I know that? Because I'm able to pull up thoughts and emotions and be with them in a manner that in my usual frame of mind, I don't think about at all. So meditation and yoga, if practiced on a regular basis, are in fact modulators of norepinephrine. It's fantastic. And norepinephrine seems to sit in the center of psychiatric challenges. And interventions ought to be pharmacologically thought, non-pharmacologically thought, and positive activity thought as well. So to summarize, norepinephrine is very widely distributed. It's a great mind-body regulator. We do underappreciate its importance, but let's not do that.